Hello and welcome. I'm Carl Svedberg from the University of Gothenburg. This is EHJ Today, and I'm here in Chicago with Professor John McMurray from University of Glasgow and Professor Scott Solomon from Brigham and Women's Hospital in Boston. Welcome. You have presented some new data from the Paradigm trial, an important trial which will influence the treatment of heart failure. So, Scott, this agent, LCZ696, can you summarize what it is and what's the effect?
Well, Carl, LCZ696 is a first-in-class angiotensin receptor neprilysin inhibitor. It's a dual-acting compound that actually consists of both a angiotensin receptor blocker, valsartan, which we know blocks the AT1 receptor, and a neprilysin inhibitor, which inhibits the enzyme neprilysin, which is the enzyme that's responsible for the breakdown of the biologically active natriuretic peptides like ANP, BNP, and CNP. So by providing this dual action, this compound both blocks the deleterious effects of neurohormonal activation in heart failure, but it also augments and enhances the natural compensatory mechanisms provided by the natriuretic peptide system. This drug has been now tested in several studies, including the Paradigm trial.
But it sounds that it increases the level of BNP.
So it increases the level of ANP, BNP, CNP, and other vasoactive compounds, such as adrenomedulin, substance P. It also, neprilysin also breaks down angiotensin II. So if you give a neprilysin inhibitor, you can actually get rises in angiotensin II, and that provides the rationale for combining the neprilysin inhibitor with an angiotensin receptor blocker.
I suppose the other thing we should mention is it also breaks down bradykinin, and that's of course why we combine a neprilysin inhibitor with an angiotensin receptor blocker and not an ACE inhibitor, because ACE also breaks down bradykinin. If you were to inhibit both of those enzymes and excessively increase bradykinin, then we'd be concerned about the risk of angioedema, which we saw with omapatrolat.
That's right. And so by combining this with an ARB, we mitigate somewhat that risk of angioedema.
Very interesting agent in that sense. But I understand it when it's after intake, it is dissolved into these two compounds.
Yeah, so this is actually a single crystalline complex that consists of 6 molecules each of valsartan and sacubitril, the neprilysin inhibitor. When it's ingested, it then comes apart. The sacubitril is a prodrug. It is then esterified to the active form of the drug, which is a neprilysin inhibitor. So interestingly, it provides both of these drugs, but the amount of valsartan that is in LCZ696 is actually more bioavailable than the same amount of valsartan in traditional valsartan.
Okay, all that being said, now we know from previous information that there are interesting effects from this agent in heart failure. So, John, can you summarize what you have presented previously?
So previously we presented the effect of LCZ696, 200 milligrams twice a day, so that gives the equivalent levels of valsartan 160 milligrams twice a day, plus on top of that neprilysin inhibition. We compared that to enalapril 10 milligrams twice a day. So it's a head-to-head active comparison in approximately 8,440 patients with primarily NYHA class 2 and 3 heart failure with reduced ejection fraction. The primary endpoint of Paradigm heart failure was the composite of cardiovascular death or heart failure hospitalization, and that composite was reduced by 20%, and it was a highly statistically significant benefit. The two components of that composite were both reduced by approximately 20%, and maybe very important in addition was the effect on all-cause mortality. That was our major secondary endpoint, and that was reduced by 16%, again a highly significant effect.
So what have you presented here?
So what I presented here was really a focus on all manifestations of worsening. You and I, Carl, know very well that these patients tend to progress over time. So what we've looked at is symptom worsening, and we've done that from a patient perspective, looking at the Kansas City Cardiomyopathy Questionnaire, looking at those patients who had a 5-point or greater deterioration, significantly less in the LCZ696 group. That was backed up by the physician assessment of the patient's clinical status, NYHA class. That was also significantly better. We asked our investigators to check an endpoint on the form which was treatment failure, the need for the addition of a new drug for worsening heart failure, or intravenous therapy, or a sustained increase in oral diuretic therapy. That was also significantly less likely to occur in the LCZ group. We looked at emergency room visits. That was another pre-specified exploratory endpoint. The total number of emergency room visits was reduced by 30% in the LCZ696 group compared to the enalapril group. And then, of course, we looked at hospital admissions. We talked about that. We've also looked at multiple hospital admissions, so not just the first, but recurrent events, reduced by 23% with LCZ696. And I think the remarkable thing was that even if patients were admitted to hospital, they were less likely to go to the intensive care unit, stayed for a shorter period of time in the intensive care unit, and were less likely to need treatment with inotropic drugs during their admission. And in fact, we even saw a reduction in the total number of hospitalizations for whatever reason, and that amounted to around 110 fewer admissions per 1,000 patients that we switched from baseline ACE inhibitor ARB to LCZ696. So those are some of the highlights of what we presented here.
What about mode of death?
Well, as you know, patients with heart failure die primarily in two ways, from sudden death or from progressive pump failure, and both of those modes of death were reduced significantly, and again the relative risk reduction for each was about 20%.
Interesting. And this was all compared to enalapril, not placebo. We have to keep that in mind.
And that's a very important point. In fact, we will present and publish simultaneously what we call an imputed placebo analysis. So we were able to indirectly compare the effects of LCZ696 to placebo, and there was around a 30% reduction in cardiovascular death compared indirectly with placebo, and an almost 50% reduction in heart failure hospitalization.
Okay. So Scott, what's going to happen with this agent and this program in the future?
One of the things that you have to think about when we have such a successful trial is what kind of patients have you not been able to include? And of course, we couldn't include all of the patients with heart failure whose ejection fractions were higher than we allowed in Paradigm. All those people with so-called preserved heart failure with preserved ejection fractions that were higher than the 40%, that was our cutoff in Paradigm. So as you know, Carl, we did a pilot trial in parallel with Paradigm called Paramount, which ended several years ago. And that trial was a way to look at whether we could improve surrogate outcomes in patients with heart failure and preserved ejection fraction. We had randomized about 300 patients to LCZ696 or valsartan and showed over a 12-week period a reduction in NT-proBNP which, by the way, is not a substrate for neprilysin, so still a very good measure of the severity of heart failure, even in the setting of neprilysin inhibition. That provided a rationale for doing an outcomes trial, which we've just started. It's called Paragon HF, and we will enroll 4,300 patients with heart failure, preserved ejection fraction, and test LCZ against valsartan.
Interesting. So we will hopefully have you back and present the results of Paragon later on.
2019.
Okay, 2019. We'll put that in the agenda. Okay, mark. Okay. Thank you. Thank you both for coming, and good luck